WHO in Geneva. Matthew is a senior health financing specialist and currently the unit head of healthcare financing at the World Health Organization in Geneva. He supports the WHO regional office on a range of health financing policy issues, and he has written extensively on issues such as health financing policy in times of financial crisis. He's adapted the WHO's guidance for countries facing fragility and conflict, and he leads WHO's capacity building work. And I have certainly been a beneficiary of that capacity building. Matthew is a global lead for the Health Financing Progress Matrix that he'll be talking to us today about. He oversees country implementation and improvement of this assessment. Matthew has worked and lived extensively in Africa, Asia, and the European region, and is currently based in WHO headquarters in Geneva. So Matthew will take us through the first presentation. IT, I trust all is set up for Matthew.
Hello, everyone, and thanks for the introduction. Hopefully you can hear me okay. Okay,
yes,
yeah,
Matthew, we can hear you.
Continue. Yeah, thank you very much. Great. Nice to join you, albeit remotely, and thanks for the introduction. Let me share my screen. I have about, I think, 10 minutes, just a quick overview. It's always a little bit of a challenge for me when I do these presentations, because I think, can you see my screen okay? Just to double check again.
Yes, we can. Thanks, Matt. Please go ahead.
Okay, thanks. Thank you. I think often there's a number of people in the room who have seen what I'm going to present many times, and there's usually a lot of people that have never seen it. So you'll just have to bear with me as I run through the next, I think, 8 or 9 slides. So the health financing progress matrix. So why did we develop this? I think there's a few reasons. You know, there's a large body, it's probably about 30 years worth of thinking and empirical work on health financing. Now, you could argue it's a relatively new subject. I think environmental economics came up beforehand in the 60s and 70s. But there's certainly by now a large body of evidence globally on what works in health financing. And essentially what we wanted to do with the matrix was to, let me put all these 3 points up. What we wanted to do with the matrix was to really synthesize this global knowledge and to translate it into an assessment which we can apply in countries to really generate country-specific guidance and recommendations. I think what the matrix offers, and I'll give a few more slides, is something that is very systematic. I mean, of course, we can all go and do a literature search and find hundreds and hundreds of papers that have been written. What we tried to do in the matrix, or what we do in the matrix, is really condense this down into something that's really very systematic and works through, helps countries work through their relative strengths and weaknesses in terms of health financing policies. So it draws on global evidence. Now, the third point there, I think countries use this, the matrix in different ways, and it's really up to a country to decide exactly how they want to apply it. Some countries are using it in the development of a new health financing strategy. Others, Uganda I speak about, I have one slide on Uganda, and currently Rwanda are actually using it formally as part of the mid-term evaluation of an existing strategy. Others, such as Ghana, for example, are embedding within some annual monitoring progress tracking system. Just very quickly, there are 2 stages to the matrix. The first, we really just map out the different schemes, health coverage programs and schemes, not forgetting the budget, right? Most money actually still flows, even in low-income countries, most public money at least still flows through the budget, but there are often additional schemes such as NHIF in Kenya and the different schemes within that also. So we map those out, and that really gives us a snapshot, if you like, of the architecture of the system. You know, what are the sort of main blocks, programs that make up the health system, right? And those blocks are important because they're the channels through which money flows, and they're the channels around which policies are made, right? So we scope that out, and then the bulk of the work actually happens in stage 2, where we have 33 questions, and we follow this functional approach, which has already been referred to already in this meeting. Just to say, actually, when we developed the matrix, you know, there were experts from Kenya that were involved in its development. I mean, Kenya is, I think it's, I'm not just saying this because I'm speaking to Kenyans, but really now has some truly global experts on health financing. So we really benefited from their contribution to the development of this instrument. So the questions are organized around the core functions of health financing, and they're mapped to performance goals. I think this is something which is a little bit different about the matrix. Some might say it's very ambitious. I think it is ambitious, but we explicitly link policies with performance, right? So it's difficult to do that in what are sort of complex systems, but we think it's important, and we felt that there was really quite strong demand from countries to get a little bit more assertive, if you like, or a little bit clearer on why certain policies matter and what improvements in performance we would expect to see as a result. So we've had a go at doing that in the matrix. The connector between policy development and performance are what we call 19 desirable attributes. These are essentially a statement, 19 statements of what a good health financing system looks like, what a high-performing health financing system look like. So we provide clearly some detail there, and it sort of sets, in a way, a series of destinations on quite detailed areas of health financing policy. And in the matrix, we map out what progress, you know, different steps and stages on the way towards those desirable attributes. So we try, again, I think just to stress the point, we think what's a little bit different about the matrix is really some quite systematic way of looking at things, some very clear delineation of what it means to make progress and what progress looks like and what a high-performing health financing system looks like. Just quickly on a stage 1, I won't spend too long on this, but this is one from Bangladesh. I don't expect you to be able to read the details, but each column represents a different scheme. You know, they have special health insurance schemes for the poor, for example, maternal voucher schemes. So we describe each of those schemes in terms of, you know, where the revenues come from, what's the target population, what are the purchasing arrangements, do they have contracts with certain types of providers, etc., etc. And then we also bring in the National Health Account, health expenditure data here. And I think that just adds some value. Again, we're trying to build that quite clear picture of the architecture of the health financing system, which might sound a little bit abstract, but we're increasingly finding it really does matter for how health systems perform. But what you see when you overlay the expenditure data, for example, is sometimes a lot of attention is given to schemes which actually handle extremely low amounts of money relative to the budget. And I think that's why in recent years, a lot of our work in WHO with many colleagues from the region has really focused on what we call public financial management to really get budget funds to work more effectively, because generally we see that still that's where the bulk of funding flows. Of course, it varies in every country. Just a note on process. we're a little bit ahead of the African Union's health financing tracker, a couple of years ahead. But we really work really closely with the AU on the ALM agenda. And I just really wanted to highlight this point that, you know, different agencies doing different things is often quite rightly a cause of annoyance for many countries. The tracker and the matrix are actually quite different. But we work super hard to make sure that these two instruments do not overlap with each other, they don't duplicate, rather they complement and speak to each other quite well. And I think Kenya is an exemplary example of just moving forward quite seamlessly on that front. And just to give a nod also to the Global Fund, who are supporting the application of the matrix in a few countries, including Kenya, in fact. Currently, we have results from around 25 countries. They're not all fully published yet. We're working hard to get these online on a database, which countries can publicly access and see what other countries are doing. Whilst, you know, I was looking at some of the data from Kenya earlier today. I think pretty steady progress in the last decade or so on many, many indicators. I think the challenge Kenya and in fact a lot of countries are facing now is to really continue pushing and increasing on service coverage without a deterioration in financial protection. What we've seen, especially in a lot of the countries in Asia, is rapid progress on service coverage, but actually at the expense of financial protection. And clearly we need progress on both of those indicators if we want to reach that ultimate goal of UHC. There's about another 25 countries that we expect to start in the next year or two with this matrix. So we hope we have a good body of evidence for countries to look at in the coming year or two. Just, I wanted to just give a quick note on an example of a completed report. Uganda, I got the final proofs this morning, so this will be going through our final sort of publication process in the next couple of weeks and should hopefully be online soon. Uganda conducted the matrix I mentioned earlier as part of the midterm review process of its current health financing strategy. One of the issues which came out is, and actually was news to me, is actually how poorly Uganda performs on financial protection relative to many other countries, let's say neighboring countries, Rwanda, Kenya, if you go down to Tanzania and Zambia. It's a bit of an outlier, actually. So what we actually subsequently have done is a deep dive into the drivers of poor financial protection, and then look specifically at, you know, what are the health financing policy areas that are maybe not being addressed at the moment, which help to explain this poor financial protection, and what can we do about it. And we're going to be presenting this case for those of you that are going to be at the AFYA conference. We're going to be presenting, we're just finalizing the presentation there now, and clearly we'll make that available afterwards. But for those of you in Cape Town, we'd be very happy if you could join the session on that. A bit of a plug. Maybe my final slide is when you look across the assessments we've done so far. I mean, there's a few themes coming out as areas of weakness that we're seeing many countries struggling with. The first is really aligning available revenues in particular with the benefits, the priority benefits that are being defined in the health sector. So maybe I've written the question up on the slide, but maybe let me just add a few words on that. We develop strategic priorities in the health sector. Of course, we do that. And Kenya, like many countries, has this essential package of essential services now. But when we look at the way budgets are structured and formed, they often do not reflect those priorities. So often a misalignment between our strategic priorities in the health sector and where flows, in particular through the budget. That's very obvious. Actually not an easy thing to make that alignment. There's a lot of, it's a massive agenda for many countries now. How do we basically get the weight of, in particular, budget and all public funds, but in particular, public budgets, to really channel their funding down to the priority services and priority populations. We know with the growth of NCDs, and a gentleman earlier mentioned about how do we ensure that HIV services don't get lost, in the PHC, but in an integrated PHC, it's really the big agenda at the moment. But how do we really get the weight of public funds to back up those priority services? A lot of countries struggling with that. Another one, a little bit more micro, but really generating good information on what's going on at the provider, at the facility level. This is, what we call like a no regret, improving good data on what's going on at the provider level to really understand who's acting, to also address that equity agenda that was highlighted earlier as a priority. That's a no regret. I mean, I think any health system, whatever, if you like, the political directions, you've got to have good data for strategic purchasing. And most importantly, not data unique to just a single scheme, but system-wide, a unified database that reflects what's going on across all providers for all citizens is really fundamental to this whole agenda. Another one, and again I mention it because it's a piece of work that we're doing in preparation for IHEA, it is really looking at again specifically the issue of financial protection, and we're really finding that the issues around pooling are coming out very strongly as if you like drivers in a way of poor financial protection. Clearly it's more complex than that. You can't pick on any one issue in health systems. We know you have to look at multiple issues at the same time, but I think as part of our learning, we're digging into these issues, and we'll be presenting some of that at the conference, and of course making it more available more widely afterwards. So, Chair, I'm going to hand back now, and I'm, of course, available for any questions after the next presenter. Thank you very much.
Thank you very much, Professor Jowett. A round of applause for him. That was a very clear and insightful presentation. Professor Matt has given us an overview of the health financing progress matrix, the 33 questions that countries need to ask themselves to determine whether we are making progress when it comes to health financing. And I was happy to note that of the countries that have results, Kenya is one of the 25 countries. The key policy issues or areas that are coming out from this health financing progress matrix review from different countries, for example, you mentioned issues coming out are whether the defined benefit packages are aligned with available resources, and whether purchasers have adequate information from providers. Those are the same questions that Kenya is grappling with. And I hope that by the end of these 3 days, we'll have a bit more insights. So Matt gave us the global picture. And with us today, we are very privileged to have Dr. Eric Tama, who leads the health financing progress matrix work here in Kenya. Dr. Eric Tama is a health financing specialist and a lecturer at Strathmore Business School. He holds a PhD and a master's in health economics from University of Cape Town. Karibu sana, Dr. Eric Tama.
Thank you, Chair. Good afternoon, everyone. So I thank you, Matthew, for the overview of the health financing progress matrix. And I will now present the preliminary findings from the assessment that we've done in Kenya. So for the initial slides, I will quickly skim through them, but just dwell on the ones that are specific to Kenya. So Matthew has taken us through what the health financing progress matrix assessment is all about and what why it's useful and what it can be used for. But specifically for Kenya, I will dwell slightly on the phases of the assessment. If you could move to slide number 3. So where we have the 4 phases of the assessment. So we have phase 1, which is the preparation, and specifically for Kenya, this involved setting up of the core team. We had an inception meeting, then the stakeholders working group was sensitized and trained, and the consultant was recruited. And then phase 2, which is the bulk of the work, and this is where we conduct the assessment, and this is done in 2 stages. We have stage 1, which involves the mapping of the schemes. So what are the different coverage schemes that exist in the country? And then stage 2 is where the assessment is actually done. So we are looking at the 33 questions that are linked to the desirable attributes, and those are the results that I'm going to be presenting in the next few slides. So if you can move to slide number 5. So I just wanted to give you an overview of what the questions are. So we have 33 questions that are distributed amongst 7 technical areas. And these technical areas are what we are calling the assessment areas. So we have health financing, policy processes, and governance. And there are questions that are attributed to that assessment area. We have revenue raising, and the questions attributed to that. We have pooling of revenues. Hopefully you're able to, I don't know whether it's possible for you to read, but I could quickly just read maybe a question from each of the technical areas. So for health financing policy, process and governance, one of the questions is whether you have an up-to-date health financing policy statement that is guided by goals and based on evidence. For raising revenue, an example of a question is how predictable is public funding for health in your country over a number of years? When it comes to pooling revenues, one of the questions is whether the country's strategy for pooling revenues reflects international experience and evidence. For purchasing and provider payments, one of the questions is provider payments harmonized within and across purchasers to ensure coherent incentives for providers. The other assessment area is benefits and conditions of access. And one of the questions there is whether decisions on those services are to be publicly funded are made transparently using explicit processes and criteria. And on the assessment area of public financial management, one of the questions is whether there are processes in place for health authorities to engage in overall budgeting planning and a multi-year budgeting. Then finally, on the assessment area of public health functions and programs, one of the questions is whether the specific health programs are aligned with or integrated into the overall health financing strategies and policies. And then I will briefly speak about the rating. So we will see as I present the results, we have different ratings for the different areas. So we have 4 levels of rating. You have the emerging, progressing, established, or advanced. And just to give you a generic explanation of what these ratings mean, so if you are talking about policy development, for instance, if you are saying you are rating that as emerging, then it means that there is no clear or approved policy statement, for instance. If you are rating it as progressing, it means that the policy is under development, but only partially, or some aspects of the policy are being implemented or the policy is being pilot tested. If we rate it as established, then it means that you have a policy document that is formally approved, that is largely reflective of global evidence and local assessments of performance problems. If we say that you are rating as advanced, then it means that you have an approved document that is consistent with global evidence, local assessments of performance problems, and it has been disseminated to a wide range of stakeholders. So that is a generic description of what these ratings mean, so that as we look at the findings, so you're able to have an idea of what those ratings mean. So remember, we've said that we are assessing the different technical areas, and we are asking different questions under those technical areas. So when you look at the results for Kenya, and just to point out that this was done in a workshop with stakeholders in the health financing, and these questions were being answered by all the stakeholders. We had discussions about this, and these are results as reflected by what we agreed to be the current scenario. So when you look at the 33 questions, you'll see majority of them were rated as progressing. So that means that we've made some progress, but we still have some way to go. So I will now present the specific findings for the 7 technical areas, or the areas of assessment. So in terms of health financing, policy process, and governance, that was rated as progressing. And just to highlight that, we have a health financing strategy that has been launched, and it is in line with international experience and global evidence. But we note that there are regulatory and legal frameworks that are not in place to operationalize that strategy or to ensure that it is fully implemented. In terms of revenue raising, that is also rated as progressing. And some highlights there is that we note the steady progress in increasing allocations to health by the government. But of concern is that out-of-pocket expenditure is still over 20% of current health expenditure. But the proposal to make insurance mandatory for all Kenyans then means that we'll have increased revenues, and that will also enhance equity in access to services. Then when it comes to pooling revenues, that was rated as progressing. We note, of course, and the previous speakers have alluded to the high degree of fragmentation when it comes to pooling, the different schemes that have different entitlements. And so that means that you have reduced redistributive capacity when it comes to cross-subsidization of both the health and financial risks across the different pools. We'll find that that is inefficient in terms of administrative costs, and the non-harmonized benefits mean that there is reduced or there is enhanced inequity in access to services. In terms of the specific questions, so for the areas of assessment that I've just presented, so this is just to show you the ratings for the different questions within those assessment areas. So when you look at health financing, policy process, and governance, all the questions were rated as progressing. In revenue raising, it was a mix of ratings, and the average rating for that assessment area was progressing as well. And then also when you look at pooling of revenues, you can see a majority of the questions were also rated as progressing. Now moving to the assessment area on purchasing and provider payment, that was rated as emerging. And the reason for that is that while there has been some progress in moving from passive purchasing to strategic purchasing, we note that the provider payment mechanisms have not fully been leveraged on to improve on quality and efficiency. And we note that tracking and monitoring of the performance indicators is not effectively done. There is an opportunity to improve on contracting and empanelment of health facilities to be able to improve on the indicators on efficiency and quality of care. And also there is an opportunity to optimize the use of data to be able to improve tracking and monitoring of performance. Then on benefits and conditions of access, that was rated as progressing. We note that benefits are well defined and there is an elaborate process of deciding or prioritizing interventions that are included in those benefit packets. But the biggest challenge is the communication of those entitlements to the public or to the beneficiaries. So you'll find that a lot of the beneficiaries might not be aware of what their entitlements are. But we also note that there is efforts to institutionalize HTA, which now will be responsible for the prioritization process of these interventions to be included in the benefit packages. Then when it comes to public financial management, that was rated as progressing as well. We note that there has been a public financial management diagnostics done in the last 3 to 5 years. The country has adopted the use of program-based budgets, but a challenge there has been the alignment of plans to expenditure. So we find that budget execution is a challenge in that. Then the other challenge has been predictability of funding, and we, I think the COG spoke to the delays in disbursements from the national government to the county government, and that of course has an impact on how funds are flowing to the health facilities. Then the other challenge is that the budgeting process, while it is clear, we find that public engagement has not been, has not been done to the extent that it should. So we find that public engagement is still a challenge. Then when it comes to public health functions and programs, that was also rated as progressing. And some of the highlights there is that most of the health programs are still dependent on donor funding, and some of the donor funding is off budget, and that means that they are not aligned with national priorities. We find duplications and inefficiencies in these programs, but there are plans to integrate them as has been articulated in the health financing strategy. So we, in terms of specific assessment questions for those areas, so you can see purchasing and provider payment was the one that performed poorly, with all the questions rated as emerging, while benefits and conditions of access, majority of the questions, the rating was also progressing. And you can see that it's also similar across public financial management and public health functions and programs. And this is just to give you a pictorial look of where the country is at. In the next slide. Yeah, so in terms of the different assessment areas, you can see that purchasing and provider payment is where we are lagging behind and where a lot of effort is needed. And then finally, in terms of the next steps as regards the assessment, so we have the draft report that is ready And the next step would be to review that with the stakeholders technical working group. Then the report will be subjected to external peer review. And then that revised report will now be validated by the wider health financing stakeholders forum. And the report will then be finalized and published. And the last step would be to launch and disseminate the final report. Thank you.
Thank you very much, Dr. Eric Tama, for that very comprehensive overview of Kenya's progress in health financing based on the health financing progress matrix. What I saw was that we are making good progress, but there's still a way to go. In most of the areas that Eric highlighted, Kenya is rated or graded at the rank of progressing in these 7 assessment areas. And the area where we seem to be lagging behind significantly is in the area of purchasing and provider payment methods, where we scored emerging, which is, at the very first step. And probably this is one of the areas that we really need to double down on during this dialogue and see how we move forward from here. So thank you very much, Eric. So we've now received a very comprehensive overview of the health financing progress matrix, both at global and at local level. As I'd mentioned earlier, you'll allow me to deviate from the program that we had a little bit to accommodate the presentation that we missed in the morning. And then after that, we'll have a brief round of plenary before we break for lunch, and we then have our panel session in the afternoon. So please stay for our panel session and the most exciting session in the afternoon. Not most exciting. And therefore, I'd like to invite Dr. Peter Chemwile to take us to the session on budgeting and public financing of health in Kenya. Dr. Peter Chemwile is a Senior Chief Finance Officer at the Ministry of Health. Karibu sana, Dr. Peter Chemwile, and then we'll have our plenary later. So please hold your questions, note them, we'll have a session for that after. Karibu.
You can hear me, all of you. My name is Dr. Peter Chemwile. I'm Senior Chief Finance Officer. Can you hear me now? Thank you very much. My name is Dr. Peter Chemwile. I'm Senior Chief Finance Officer at the Ministry of Health, State Department for Medical Services. As you know, the ministry has been one. Now we have 2 state departments. One state department is in charge of medical services. The other one is in charge of public health and standards. So I'm going to look at the budgeting and public financing of the health sector in Kenya. And I'm going to pay particular attention to the process that we do during the budgeting process. Then I look at the key allocations and the principles that guide us in making those allocations. And then I shall give a short brief on the challenges that we face in the budgeting process. And finally, I will indicate the priorities that we have been using to allocate the resources that we do during the budgeting process. So I hope that you can follow me on the screen. I've just mentioned that the first thing I'll do is the introduction. Then I'll look at the overview of the PFM process, because this is the process that guides budgeting in the public sector. Then the key allocations. What are the monies? Where is the government putting its money as far as health is concerned? Then the priorities for the MTEF, the emerging issues, the challenges that we've been facing, and what we think would be the recommendations in relation to that. Now, As you all know, the Constitution of Kenya provides that health is a constitutional right, and therefore the government takes the financing of health as a very serious issue, and the budget is funded both from borrowings and from local resources. We use an annual finance plan to budget. We use the guidelines that we get from the National Treasury in preparing the budget. We use the Public Finance Management Act in allocating the resources. The Public Finance Management Act gives the procedures and processes and defines what has to be considered while allocating the resources. And it's from the PFM that we get the guidelines from the National Treasury that initiate the process of budget making. Now, as you know, initially we used to have what were just called annual projections, but this has now moved. Instead of the projections, we have got allocation to programs in what is referred to as the program-based budget. Now, you may also be all aware that the health is it a shared or is it a devolved function? I think it's a shared function between the national government and the county government. So in relation to the national government, the resources are allocated using the PFM Acts. In relation to the county government, the funds for health are normally sent to the counties together in the county allocation bill. And it is the county assemblies that determine how much they will allocate to health as a sector in the county. But when it comes to the national government, we normally use the guidelines that are issued by the National Treasury because the National Treasury is the leader in the process of budgeting. In making the budget preparation, there are normally 3 guidelines that are issued. The first one is the guidelines on preparation of the budget. And this tends to point out the key priorities that the government wants you to allocate in terms of the projects, in terms of where you should be putting the funds, in terms of your prioritization. Then we have got, once you've prepared the budget, of course, the National Treasury issues the guidelines on implementation. And finally, there is also the guidelines on the finalization of the budget. Just to mention the 3 guidelines in a little bit of detail, the guidelines on preparation of the budget is normally issued in August. And this is the guideline, this is the circular that normally initiates the process of budget preparation by saying these are the sectors that we are going to have, these are the processes, these are the kind of documents that we are going to have, and these are the timelines that are expected. The second guideline is on implementation of the budget. This is normally issued immediately the budget is passed, and it guides on how to implement the budget. You may have money in the budget, but the National Treasury may decide that you will not use that money, or you don't spend that money without further approval. For example, if you have got money on recruitment, the National Treasury may issue a guideline that you must get approval before you recruit, even when you have money. Or purchase of motor vehicle, you may not purchase until you have other approvals other than having the funds. So I have mentioned that the counties are funded directly through the exchequer, although we still issue, especially at the moment, we still issue some funds to the counties through what we call conditional grants to address specific programs. Okay, in a nutshell, I want to mention about the process of budget making. This is normally initiated first by policy. The government of the day has got what it emphasizes. Like, I think the current government has UHC as one of its key priorities. And so you will find, as we come to look at the figures, you will see that UHC has the highest allocation of budget in terms of item other than the sagas, other than the states, the state agencies. When we look at the figures, you will see that UHC has an allocation of 11 billion in development and 5 billion in recurrent. That is the highest single figure that has been allocated in the budget. That's because of the policy of the government. Then after the policy, the next issue that is looked at during the process of budget making are the strategic and operational planning. This is where you make your work plans. And then after that, we have got the budget formulation process, which we shall be looking at in short, so that you can see how do we arrive at the figures at which we arrive through a process that is called the sector working group that involves the public. The presenter had said that the public is not involved, but you'll be seeing how it is involved. And then we have got the process of budget execution, then the accounting and reporting, which is done through auditing, and also the evaluation process. So the budget making calendar has some key dates which must be met. I mentioned that on 30th August, the National Treasury is required by the PFM Act to issue a circular to kickstart the process of budget making. And then in September, it is expected that there will be a review and update of the development plans. Then by 30th September, a document called the Budget Review and Outlook Paper, or BROP, is developed. This document normally reviews the expenditures and the trends in the last 3 years. And it is this document that will now guide the allocations as you come to the allocations in the following, in the coming period. Because if a sector is not absorbing, then it will have its allocations trimmed down. Then by 15th February, we should have the budget policy statement, which guides the government policy in relation to the budget. And by 30th April, the estimates are submitted to the National Assembly. And 30th June, the budget must be approved. Now, that section is just for information on the key process that are specified in the PFM in the process of budget making. I want to skip it because it's a little bit detailed, but it will be available to you in the document that we are giving with the Secretariat for sharing. It basically indicates to you the stages of budget making process as required by the law. In a nutshell, what it indicates is that the process of budget making involves the Cabinet Secretary of the National Treasury and then the sectors, that is the ministries, the departments, and the independent accounting units, and then the preparation of the policy documents, which is the budget policy statement, and then the approvals that are done through the National Treasury and Parliament. Now, I want to look at the allocations and the process that is used during allocations, because this is an important process. Many people keep on wondering, how did you arrive at this figure for health, and this figure for agriculture, and this figure for roads and such. Now, at the National Treasury, we have a group, we have a unit called the Macro Working Group, and the purpose of this group or section in the National Treasury is to review the past performance of both revenue and expenditure, to review the absorption levels of each of the state departments or spending units, and also to reflect in the last 3 years how has generally been the economy performing in terms of the GDP, because the Act, the PFM Act requires that as you make the constitution, there are certain principles which you must follow. You must not, for example, borrow too much so that you burden the future generation with a lot of debt. We call them the principles of budgeting as stipulated in both the PFM and the Constitution. So they look at the fiscal deficit. How much, for example, are we going to borrow to finance our budget? They look at the policies of the government of the day and decide that based on the anticipated resource envelope, this is the amount that we are going to allocate to health. This is the amount we are going to allocate to education. This is the amount we are going to allocate to each of the 10 sectors that are made, that make up the entire Kenyan financial ecosystem. Once they declare that this is the amount for health, that is now called the ceiling, and it is that money that the ministry or the State Department and other subsectors, as we call them, are going to share from within that whole basket. Now, if you look at the allocation in terms of the sector in health, having been given a particular ceiling, if you have been told that you are going to have 100 billion in health, go and allocate it. Over the years, the Ministry of Health, as it has been, now we have got the Ministry of Health with 2 state departments. The emphasis has always been on preventive, promotive, reproductive, maternal, newborn, child and adolescent health services as one of the biggest section or program that is allocated money. After that, the next major allocation has been in the National Referral and Specialized Services. That is the national hospitals. As we look at the allocation, you will realize that after the UHC, which we said has the highest allocation as a single line, the next major allocation are the national referral hospitals. You'll find Kenyatta National Hospital being allocated 21 billion. You'll get Moi Teaching and Referral Hospital with an allocation of 12 billion. You'll get Kenyatta University Teaching and Referral Hospital with an allocation of around 6 billion. All right. Let me rush through. I'm told my time is over. Now, when you come to look at the figures, I want to compare the current figures that we have and the next figures for the next financial year. So in this year that we are closing, we had a total of 116 billion for the Ministry of Health. Next year, we have got 141 billion for the Ministry of Health. This money is shared between the 2 state departments, where we have got the State Department of Medical Services having 69 billion in the current year and 63 billion in the coming year for recurrent. And for development, Medical Services has 41 billion in this year and 53 billion in next year. The State Department for Public Health, which is a new kid in the block, has got 2 billion in the current year. And next financial year that we are starting in July, they have got 17 billion for recurrent. In development, they have 2 billion this year, and next year they have 7 billion. That is just a summary. So we can quickly, although I've been told I have just 5 minutes, look at where the money goes. How are those resources? Where do they go once they come to the ministry? I want to concentrate on 2024, 2025. No, that's a projection. Let me look at 2023, 2024. If you look at the entire allocation to the Ministry of Health, the current expenditure was 80 billion. Out of the 80 billion, I'm combining the 2 state departments. Column 3, the entire money for recurrent was 80 billion. Out of that money, 14 billion was used for salaries, what we are calling compensation to employees. Then 2.4 billion was used for goods and services, cleaning services, operations, motor vehicle maintenance, travel, and all that kind of stuff. 63 billion of the 80 billion was transferred to the SAGAs. That is KEMSA, KNH, Moi Teaching, all those parastatals that you hear about. And then 103 million was paid as gratuity and pensions, which we are calling social benefits. Then we had 242 million, which was used for purchase of non-financial assets. That's the furniture, the motor vehicles, the printers, and all that. Now, when you come to the capital expenditure, the entire ministry had 60 billion, if you are moving with me. And out of that 60 billion, we had 55 million, which was used for personal emoluments. Now, why we have got personal emoluments or salaries in development, it is because we have got some donor projects, which includes some components of staff. We have some projects which have contracted staff, like the COVID-19 emergency support program. It has employed some contracted staff, and that money is provided for under development. Then 4 billion was used for goods and services, which I've told you are the procurements within the ministry. 49 billion of the development budget was transferred to the SAGAs, the KNH, the Kenyatta University Referral Hospitals, and the KEMRI. And then we had 6.5 billion being used for non-financial assets in development, bringing up the total, which will bring up the total expenditure to 141 billion. In a nutshell, I think there isn't much time. So when you look at the total allocation of the Ministry of Health, is far much below what was expected by the Abuja Declaration, which indicated that the budget allocated to health should be 15% of the national budget. As per the figures that we have given, we were doing 5% of the budget. Now, what are the priorities for the medium term for the ministries, or what are the areas that the ministry is putting its money? Number one, it is the universal health care, which we have mentioned that in the coming year, the year that we are going, we have allocated out of the 141 billion, we are giving around 16 billion. 11 billion is going to universal health care insurance for these people who are not able. We call them the poor of the poor. We will pay that money to NHIF, and then it will provide insurance. And then 5 billion of that UHC money, we shall use it to pay for staff who are recruited under UHC. We have staff who have been recruited to support UHC, including the CHVs. Even this year we had some money, but we lacked the framework on which to transfer the money to the counties. We did not have the actual figures. We were supposed to give 2,500, and the counties should have given 2,500. I think I'll stop in 1 minute. So the other priorities we have is making health affordable. We also want to support the strategic interventions such as malaria, HIV, TB, which we are supporting together with the donors. We are also hoping to improve the commodity supply by undertaking reforms in KEMSA and such other bodies. We are also trying to create a fund for HPTs, a revolving fund. And we are also creating a fund for the non-communicable diseases. We have an allocation this year of 300 million. let me just finish up. So we have got a few emerging issues or challenges. One of them is the climatic change, which we believe has got is a risk to health. We also have another emerging issue of mental health is a big problem. We have the issue of ICT in health. Health is not well, it's not up to date in matters ICT. We also would want to harmonize the regulations and have one maybe health act that encompasses all the health issues, including the facilities. Each of the facilities that we have, each of the referral hospitals are operating under a separate legislative framework. We would also want to address the issue of human resource for health because we feel that there are issues that need to be addressed there in terms of numbers. We would also want to increase the amount of our strategic interventions because the donor provisions are reducing. I think you have the direction of where we are heading. So let me stop there. We'll address any questions that may emerge. I think I had more than the time allows. Thank you very much.
Thank you very much, Dr. Chemwile. That was a very comprehensive presentation, walking us through the PFM and budgeting process for Kenya, the guidelines that support these processes based on the PFM Act, and also what the priorities for the Ministry of Health are in the medium term moving forward. So thank you very much. I think the time we allocated for you was not enough because I could see everyone was really keen to listen, but I'm afraid we were running out of time. I trust that we still have Professor Matt online, and that will be available together with our two other presenters, Dr. Eric and Dr. Chemwile, to be able to answer some questions from the audience. And so, ladies and gentlemen, this is really our chance to engage with our three presenters. You can see we are not tracking well on time, and so I'll therefore not take very many questions, but I'd like to make sure that the entire room is represented. I'd like to ask you to keep it brief, your name, the organization that you represent, one question, and tell us to who it's directed, very briefly. I'll start with that young gentleman there. We have some mics here. Excuse me. I'm looking for a short black woman to prioritize. We often get, we are not seen usually. A short black woman, right here, great. So next will be Dr. Wala. Please go ahead.
Is it working? Okay. My name is David Kabera, policy officer at Waki Health. My question is to Dr. Chemwile. Thank you for the presentation. I'd like to ask, once the macro group has decided on the allocation to health, what guidelines dictate the prioritization, the allocations to the specific budget lines within health? That's UHC, referrals, hospitals. Are there guidelines that dictate that and whether they are accessible? Thank you.
Thank you. Thank you. Dr. Wala here. Anyone on this side?
I'm going to take a mic.
I'm trying to get someone from each region. Please go ahead, Dr. Wala.
Thank you very much. My name is Dr. Wala, short black woman, Vice Chair of Kenya Healthcare Federation. My question is to the last presenter. I'm sorry I missed the name. In terms of accountability, is there a report towards just addressing how much went to health and how much was actually utilized and how much was misappropriated, for lack of a better word? Thank you.
Thank you, Dr. Wala. The lady there at the very end, and then we'll come back to Kama. I was trying to make sure that there's representation because we heard from you earlier. The lady there at the very end, yes, please go ahead. So we'll take her, we'll take Kamau, and then we'll wrap it there. And then we'll hear from our presenters.
Thank you, Chair. Mine will be only one question.
Basically, service delivery. National government was left with regulation and policy. I want to tell you, we are battling in the counties. We have the clients, we have the patients, we have the population, we have the people. But we have no resources. Everything is being controlled from MOH. And I want to tell you.
Please, could you please get to the question? Thank you.
The question is, why don't they devolve the money to the counties? Let them bring the money to where people are. We agree that they sit on the table to negotiate with the donors who are the supporters of this. We do appreciate, but let that money be disseminated to the communities so that people will get value for money. Thank you.
Very much, very important question. One last question here from Kamau, and then we'll also get 2 questions from the virtual audience. One question, please, brief.
Thank you very much, Dr. Tama. You have showed us the scorecard. We have seen it. Under the AU, or the African Union, of which we are member states, they also have the scorecards from the states, but they also have the scorecards from the civil society. Because we're not going to take only your side. You could tell us what you want us to hear. So I think it's important to make sure that we have a dual system, because that's the way we are going to counter-check it. Thank you very much, sir, from Peter from FCFO. I asked a question in the morning and it was happened. You look like the very good person to answer the question. This year's budget is less with 5.6 billion. If I recall, that 5.6 billion was what we put in the last quarter for sustainability for HIV, TB, malaria, non-communicable diseases, maternal child health, and blood transfusion, which was put there through a cabinet memo. And here you are cutting it and asking us to continue. Could you explain that discrepancy of 5.6 billion?
Thank you very much, Mr. Kamau. Finally, we'll have our last 2 questions from our virtual audience. IT team, please go ahead and unmute them. 2 questions, please, and then we'll hear from our presenters.
Thank you very much, colleagues. My name is Stephen Anguba Shikoli. I coordinate TB Champions, which is a network of TB-affected communities. The last presenter highlighted that there was money that was set aside for CHVs, community health volunteers, that was supposed to be 2,500, and then due to lack of frameworks, the money was not used. So I would like to know what is happening with that money. Is there a possibility for that money to be allocated to things like TB and HIV? The last one is about
I'm afraid we'll take 1 question from you in the interest of time, so that we give the other person online an opportunity as well. Please go ahead, next person.
Hello.
Is that Joseph?
Hello, this is yes, Joseph Mang, yes. Yes, I'm Joseph Mang from KMTC, and I'm keen on issues on UHC staffs. We know the contract has ended for some of the KMTC staffs, and there is nothing that is going forward on it. I don't know how are we transitioning now from
and by stakeholders in the field of financing. So it is not my assessment. So for instance, the results that I was presenting today, this as a result of a workshop that we had with all the stakeholders working group. And also to note that there are efforts to align the financing matrix assessment with also the AU tracker so that they speak the same language. Yeah, thank you.
Thank you, Eric. Dr. Chemwila, please go ahead very concisely. I'm told we are way out of time. Asante.
Thank you, and thank you for giving me less time. I realized I aroused more interest. Now, the first question was on once we get the ceiling, how then do we allocate to specific lines like UHC and others? My response to that question is that it's a process. For example, if it's UHC, they have specific commitments which they have said that they want to insure 1,000 or 1 million this year. Next year, they want to insure the 1.5. So we look at that and see the growth that the ceiling allows us. If it's the allocations to the SAGAs or to the state agencies like KNH, MTRH, Kenyatta, we ask the SAGAs to come with the expenditure frameworks. They come with their payrolls, we allocate PE. They come with if they have contracts like cleaning contracts, operations, they must bring them. Then we allocate until we see what remains. So we give the allocations depending on a need basis. If we have a balance, then always we don't have a balance because the resources are less than the requirement. So yes, there is a formula. It's not arbitrary. The other question was touching on the reduction in this year's current budget at 5.6 billion. Yes, the reduction was 5.6. It touched on 2.8 billion, which was a reduction. No, 1.8 billion was from the leasing, what is called the medical equipment leasing scheme, which was reduced by 1.8. The reason this one was reduced was because the contracts were ending and there wasn't a framework. So what we needed to pay the current contracts until the end of the financial year is what we were left with. Otherwise, we would have had an unspent balances in that. But so apart from 1.8 that was reduced from MES, the other reduction was in vaccines and immunization, where we had a reduction of the balance. And the problem here was absorption. The money was not moving because there are some discussions which have not been concluded in relation to the way that program of vaccines and immunization is being run. Then there was the other question about the oversight that is done to the ministry. Yes, we have got oversights. This is done by Parliament all the time when there are issues. The Parliament oversights. We have got the Auditor General who also oversights. There is a parliamentary committee. Yes, there is oversight. And accountability issues are always addressed by the specific agencies which have been created for that function whenever they arise. Finally, there was a question on CHV money that we had. So we couldn't just transfer money. We required a framework, and now a process of inter-parties agreement has been initiated. And once that process is there, then we are going to revote those funds. And once there is a process of determining the actual numbers on the ground, then we shall give our counterpart of 2,500 per the CHV on the ground on condition that the county also undertakes to give the other 2,500 shillings so that the CHV has got 5,000 as a stipend.
Thank you very, very much, Dr. Chemwile, and you indeed were very concise as you responded. I can see there are still very many more questions from the audience. I'd like to invite you to engage with our presenters over lunch. I'm afraid we'll have to cut it off. Please, I'm afraid we'll have to engage him over lunchtime. I'm being told we are way out of time, and we also have an afternoon session. Please forgive me. So thank you very much, ladies and gentlemen, for your patience this afternoon, and a round of applause for our presenters. Asanteni. So we are breaking for lunch now. Dr. Wangi, I don't know when you want us back from lunch. I know it is not at 3 o'clock. I doubt we have a full hour for lunch. Okay, since there's no guidance, can we please be back here at 2:45 p.m.? Asanteni.
Recording stopped.
Lunch is served at the Nyama Choma Ranch. You'll go straight ahead and then to the left. Let's please be back at 2:45 p.m. Asanteni. We also advise to carry all our bags out because there'll be a security check over lunchtime. So please carry all your bags out.
Please, attention please, you don't leave any of your items in the room. Please leave with everything, your laptops, because we have a security check that will be conducted immediately after this to allow preparations for the afternoon. Kindly also ensure you have your badges for lunch, because we don't have meal cards. Please carry your badge. That will be your passport to lunch.
Grazie.